Go. All right, we ready to go? Nope.
Yes.
Okay. All right. So thank you everyone for having me back. I think I gave a talk about a year and a half ago. This month we're going to talk about muscle tension and how muscle tension can be, for many people, can actually be an underlying reason, or at least an underlying contributing factor to having a chronic headache. There's a lot of talk about headaches, migraines, and so forth, so we'll talk a little bit about that. Primarily, the outline today is I'll talk about the types of headaches that we normally see, specifically the ones that can be related to the muscles of the neck and the head. We'll talk about muscle pain and how that works. Some of you may have remembered I gave a talk on dry needling, which talked a lot at length regarding muscle pain mechanisms. So we'll talk about that, and ultimately physical therapy treatment that has to do, that can, that there is treatment out there from the physical therapy standpoint to deal with headaches, and then we'll have some time for questions, hopefully. Okay, so for this talk, we'll kind of break it down to three types of headaches. There's something called a migraine, a tension type headache, and then a cervicogenic headache. For the most part, those three types of headaches all have an underlying factor of muscle, some more than others, and we'll talk about those three moving forward. So a tension type headache is the type of headache where usually it has to do with muscle pain, and we'll probably talk about this one the most, because this one, the 52% of headaches, is related to a tension type headache. Usually most people feel this as like a kind of like a tight band around their head, and they feel like there's a lot of tension. And sometimes with the other headaches, a lot of times there can be some sort of triggering factor or like an event, whether it's having a stressful day. A tension type headache, though, can really be related to a prolonged poor posture or prolonged muscle weakness and so forth, as we'll talk about. So usually this type of headache is really more of a referral muscle pattern, which we'll talk about, that has to do with muscle pain. The second type of headache, which is usually interchanged with the headache in general, is the migraine. For all intents and purposes, a migraine is different than a tension headache in the fact that, as I said, and there's a little bit in the red writing over here on the bottom of the slide, and that's more associated with a neurovascular event. Now, don't get scared. It doesn't mean that someone's having a stroke per se. It's more about the fact that usually people describe it as a pulsating type feeling when they have a migraine. And if you see on the second part over here, I wrote down here, photo and phonophobia. So it's associated symptoms are neck pain, muscle tenderness, myofascial trigger points, which is muscle pain, nausea, vomiting, and then photo or phonophobia, which is pretty much sensitivity to light or sensitivity to sound. So that takes about 18% of headaches that we will see. And it's to make it simply, a simple way to describe it is that it's a neurovascular event where there's something to do with the blood flow in the brain, where the main arteries that are supplying blood to the brain, there's nerve fibers that are around those arteries, and those get inflamed sometimes and cause pain. And that's usually kind of the differentiation between a migraine and a chronic tension type headache. The third one is something called a cervicogenic headache. And that really, if you look at the title of the word, cervico means neck, and then genic means it's originating from the neck. So it's usually more related to something coming from the neck and going to the head. So this can also be very, very common in terms of pain. But there's definitely a referral pain pattern that comes along. But again, of the three, we got the tension type headache, which is 52%. 18% is migraine, and then 12.5% of headaches is cervicogenic. If you add up the math here, I'm just thinking about it right now. So my basic math will tell me that there's 70%. Yeah, so 82.5% of headaches are at least three. So it looks like we're missing some. So there are other headaches, and that has to do with sometimes a vestibular headache, which we're not talking about because that has to do with more of the vestibular system. And there are other headaches as well, which have to do with more of a neurological basis, which we won't talk about today. But these three headaches I wanted to focus on because all these three have a root basis of, or a contributing factor in terms of muscle pain. Okay, so muscle pain. So the interesting thing about muscle pain, again, as we talked about within dry needling lecture, is that muscle pain has a specific characteristic where muscles can refer pain to other areas of the body. The best example, or the clearest example of this, which is unfortunately if someone's having a heart attack, for example, which is the picture on the right side over here. If someone's having a heart attack, a lot of times one of the most common symptoms is that they have pain going down the arm. Now, the question is, well, if the heart is the source of the pain, then why is it that there's pain being perceived in the arm? And the reason is because in the spinal cord, where you have all the nerves coming together in the spinal column, think of it as a cup of water, and that cup of water is spilling over. So it's receiving information from the heart that the heart's in pain, the heart is having a heart attack. So the fluid is spilling over, but it's going to some of the other nerve areas on the spinal cord in the same segment. It's almost like it's going to, let's say, the 10th floor of the building, and then from the 10th floor, it's spreading to the 12th floor, to the 13th floor, going back down towards the 8th floor, the 7th floor. So it's kind of moving up and down. And that's why people have something called a referral pain pattern, where pain will kind of migrate downwards down the arm. I noticed that I'm looking at the video screen the whole time, so let me take my video screen away so I'm actually looking straight ahead. Okay, it's probably better. So it's pretty much where there's a referral pain, where the pain is kind of traveling down the arm. And by doing that, the pain is perceived, as you can see from this picture over here on the top. The pain is being perceived by the brain as coming from down the arm. But really, in this particular case, this woman is actually feeling the pain. It's actually a muscle that's actually called a trigger point. There's a trigger point in her shoulder blade. And as you can see here on this little chart over here that I have on the bottom left side, usually muscle pain is a little bit more difficult to locate as well. In terms of like someone gets a scratch on their hand, they're going to feel it a lot better. Usually the tolerance for muscle pain is a lot less tolerable. Okay, so when it comes to muscle pain, and we talk about muscle, so I'm sure many people have heard about the term a trigger point. So there are two types of trigger points. There's something called the latent trigger point, which is pretty much where spontaneous pain can be evoked through digital pressure, meaning if I press my hand, one second, open this back up again. If I, for example, press on my hand here, and I feel discomfort or pain, that's considered to be a latent trigger point where the muscle is there's a taut band in the muscle. It might feel like a nerve, but it's actually more of a muscle. And I feel that little trigger point right there, and it refers pain to that, and the pain is localized. That's considered to be a latent trigger point, meaning it's not going anywhere else. It's not working spontaneously or spontaneously working to get pain. However, that's in contrast to an active trigger point, where there's an active trigger point, as you can see from this picture, there could be some pain going on in the shoulder, but it can actually move down the arm. And it's called refer pain away from the trigger point. So that's the idea of an active trigger point. So again, a latent trigger point is a trigger point or a muscle band that when you press on it can reproduce pain. An active trigger point is where you press on it and it will, and that type of pain it doesn't actually, let me rephrase that. You don't have to press on it spontaneously. It can give a local and a referred pain pattern down the arm. So that's the difference between active and latent. All right. So here's another example of some referral pain patterns that happens from pain. So as we can see here, we have some pain coming from the upper neck area on the left side here. We have some pain from the shoulder, pain from the glute muscle, which actually kind of sometimes people think is actually back pain, but sometimes it can actually be coming from some of the glute muscles or the back muscles. And then here we have on the bottom right, we have a picture of some pain coming from the trapezius muscle, which is the neck. And you can see it kind of curls around this way. This is a very common pain pattern that we see. So thinking back to those three types of headaches, right? We have tension type headaches, If you think about a tension type headache, especially if the tension is on both sides, sometimes people can have trigger points or muscle in their neck that can actually refer to the head. Again, meaning the pain source, meaning those trigger points, those muscles that are banded up are in the neck, but for some reason they're causing pain or refer pain up to the neck. And again, that's because the brain is perceiving pain coming from not just this area, but also pain coming from the head. So that's why sometimes a headache can be coming from the neck, but it's actually going to the head. Migraines obviously is more neurovascular, as we talked about, but there can be muscle related things. I mean, imagine if someone's having a migraine, they're probably balling up, and a lot of times there could be muscle bands or trigger points in their neck. So okay, so that's the idea of a muscle pain, is that you have a referral pain pattern. Okay, so let's talk a little bit about how these trigger points work. So just to review, a trigger point is a taut band of muscle, meaning the muscle can get tired or overused. As you can see here, there's a little bit of a circle here, and this is pretty much showing the process. So for example, let's start from over here. If somebody has a taut band of muscle in their neck, meaning, let's say, for example, somebody's sitting all the time at their computer and their neck is always shortened and it's tight. Many times, if that muscle is being overworked, it can cause a tightening or a contracture. It's a localized contracture. And that's what it looks like over here. This is what a contracture looks like. So it almost looks like it's like a nodule where now the fiber starts to shorten and kind of ball up. So it's not a contraction, it's a contracture. When that muscle contractures, or when that muscle starts to ball up, as you can see over here, there starts to be a decrease or an absence of blood flow, or there's not as much blood flow going to that trigger point. Now that there isn't as much blood flow going to that trigger point, blood flow brings oxygen to the muscle. So as the oxygen goes down, the oxygen content goes down because now there isn't as much blood flow running through that muscle trigger point. The oxygen goes down. Basic chemistry is basically where now that the oxygen goes down, the acidity level goes up. So again, there's a muscle contracture where the muscle is being overworked or overused. Let's say, for example, somebody's at their computer, the band tightens, and then now there's no more, the blood flow is not as easily perfusing through that area. Oxygen will go down, and the acidity level will go up. All right, so it's an inverse relationship. Once the acidity level goes up, now that is a big trigger or pain-producing trigger to all these pain-modulating mediators or these pain chemicals in the body. So that's this cycle right here. So that's what a trigger point is. So again, we have trigger points all over our body. After a workout, you might feel a lot more trigger points or a lot more tenderness in your muscle. Again, there's a lot of energy going on. And when the energy is going on, when there's a lot of energy going on, that can end up the muscle can end up fatiguing and balling up. When that happens, those trigger points kind of increase and they decrease the blood flow, oxygen goes down, acidity levels go up, pain starts to get stimulated through that area, and that's where people start to have pain. An active trigger point, as we talked about, right? The main factor of the active trigger point is that it refers. So that means that trigger point is becoming so painful and so tight, and there's so much pain going on right now. Those pain modulating mediators are so intense. The pain, the amount of blood flow and the amount of oxygen going through there is reduced to the point where it starts to really cause pain, not just at that spot, but it starts to be perceived in other areas of the body. So you can see how this would be someone who's always forward on their computer, or someone who's in a car accident and they all of a sudden have whiplash. Those muscles are called into play, and those muscles are traumatized. Trigger points can form. And here's the next slide. So there are four, I would say, arthritis if you think about arthritis, if somebody has some sort of joint wearing down, this is actually a picture of the knee, but if somebody has a joint kind of wears down a little bit, there are times when the joint is worn down. So now the muscles have to stabilize the joint a little bit more because the muscles are working so hard. Those muscles are developing those trigger points. The same thing comes with trauma. For example, whiplash. This is a picture of whiplash here on the left side. So there's a forward and a backwards motion very quickly. Muscles are called into play very quickly, and they're not really able to handle it, and they can really get aggravated. And that's another source of trigger points. Trigger points, obviously, as we talked about before, chronic overuse. Right at the end of the day, you're at the day with, you're on your phone, you're at the computer, and you're constantly doing this day after day. Those muscles are being stressed and tired. There's going to be trigger points that develop in those muscles. And then here, another one is here. This is a picture here of visceral pathology. And this is probably not really as applicable when it comes to the head and neck, but it is possible for trigger points to develop secondary to something going on in the stomach. As we talked about, the circuitry is intimately connected between the muscles, the brain, and the organs. Okay, so the question is, how can we address trigger points in physical therapy? Now, again, trigger points and trigger point development, as you can see, with all these three types of headaches, migraine, as we talked about again, I'm going to go back to it. Sorry for going through all the slides again. With a tension type headache, the associated symptoms are generally, as you can see here on the bottom here, myofascial trigger points, which is what we see. We see muscle pain with the head and neck. And then if you see here, it says here, decreased neck flexor endurance, which basically, if the muscles in the front of my neck are weakened, it's very possible for my head to start to get a forward posture and always have my neck kind of poking forward. If that's the case, all the muscles in the back of the head are working really hard to keep my head over my body. So it's almost like if I have a bowling ball, let's say, for example, take this jar here. If I have let's say I have something on my hand, and then all of a sudden my hand starts to go forward, meaning my head starts to go forward, all those muscles in the back of my neck have to work extra hard to keep my head up. Or if my head starts to go forward, all those muscles have to keep my head up. So if that's the case, if you think about it, all those muscles in the back of my neck are working really hard because the muscles in the front are weak, right? The muscles in the front are weak, so they can't keep my head, they can't tuck my chin pokes forward, my head goes forward. That can lead to trigger points and this feeling of a tension headache in the head. And we're going to look at that in a minute. I'm going to show you some pictures of some tension related muscle related patterns. Again, migraines, someone has neck pain, muscle tenderness, right? They're going to have, if someone's having a migraine, they're going to start to, there's going to be muscle component to that. Even though the migraine itself, the pathology of it is more neurovascular, meaning it's coming from, and there could be also some, allergies related to this and different other things. But let's say, for example, if someone's having a neurovascular event, they may actually still have other muscles that are getting tightened up and squeezed, and that could be leading to trigger points as well, because the muscles are working so hard, they're not releasing, the oxygen isn't going through those muscles as well. And then we have the cervicogenic headache. This is actually a lot more common. It says here trauma and non-trauma, but something like this is very common with whiplash. Because forget about the head. If somebody's neck goes back, the top of their spine gets bent back really quickly, and that can actually lead to all those muscles being traumatized, and especially the muscle in the front here, which we'll talk about, the sternocleidomastoid. Okay. All right. So with physical therapy, the best, I guess the most straightforward way to deal with it is obviously, think of it like this. If a muscle is tight and a muscle is weak and a muscle is overused, it can develop into a trigger point, into a taut band. Think of the taut band as being like a computer on this left side here, a computer that is constantly loading. It's frozen and you can't move forward, you can't move backwards. That muscle band is tight, it's not releasing. So what do we have to do? We have to restart the computer. We press restart. You got to get it to release. However, if you don't upgrade the computer, it's going to go back to that same state again. Again, it got like this for a reason. It's like this because the muscle's weak, the muscle's tight, the muscle's overworked. We release it. If you don't change, whether it's the muscle strength, the habits, stress in your life, whatever the case may be, if you don't restart that, if you don't upgrade that computer after it's restarted, it's just going to slowly go back to the original, to its original state. So physical therapy comes in is that we can try to, what we're going to try to do is we want to work on trying to release those muscles and then strengthen them. Think of a tight muscle as being a weak muscle. A lot of times people think of tight muscles as being, weak muscles as being very spread out and and stretch. That is true, it is possible, but especially when it comes to trigger points, very oftentimes parts of that muscle can actually be more tight than usual. And because they're more tight than usual, they have a harder time shortening and lengthening because muscles shorten, muscles lengthen. Okay, so again, physical therapy is we gotta restart that frozen computer, i.e. the trigger points, and then we got to upgrade them with exercise, with a retraining. Okay, so here's an example of a muscle which is probably one of the most common players when it comes to headaches. This is the trapezius muscle. As we can see, the trapezius muscle is kind of like a diamond shaped, or a trapezoid. I guess it's called trapezius for a reason. It's a diamond shaped muscle. There's one. This is the one on the right side. This one has actually been removed on the. I'm sorry, on the left side. On the right side's been removed. But this muscle over here is one of the main muscles that helps move your shoulder blade, as well as it's a big muscle of the neck and the upper back. When people have a forward head posture, when people are in, for example, a car accident, this muscle, because of how big it is and how long those fibers are, it has to do a lot. And when it's doing a lot for a long period of time, for many, many hours over the course of the day, or it could be from just a traumatic event, these muscles can get very tight. As you can see on these three pictures on the right side of the screen, these are three different areas of the trapezius muscle, three different areas that actually are well-documented trigger point locations that can refer pain. So actually the one on the bottom here is actually not as referral, as you can see, because it's the spot, the X and the red spot is kind of where all the pain is. But if you look on the top right, this is probably one of the most common patterns that we see in the clinic, is that the upper part of the trapezius muscle, that very upper part, a lot of times is really, really tight, especially with chronic overuse, forward head posture, as well as driving in the car. People driving the car all day long, they get that. I would say it's very common with following a car accident or some sort of fall. So those muscles on the very top portion of the trapezius muscle over there actually have this kind of I don't know if you want to call it like a question mark type of pattern. It kind of looks like a question mark in a way, where it kind of starts from the top of the head to the side of the temple here and kind of comes around and then back of the head like this. That's usually a common referral pain pattern when people have trigger points in their upper trapezius muscle. This is something that we see very often in the clinic. Another one is the sternocleidomastoid, which is a muscle which is attached to the base of the skull, but then comes around to the front. So as you can see on the left side over here, there's a little muscle that's kind of at the base of the skull, kind of comes down to the collarbone. And as you can see on the picture on the bottom there, this is exactly what happens at whiplash, because that muscle has to control, the muscle attaches here, comes around this way, it has to really control that whiplash, or that really quick motion. A lot of times whiplash has a backwards and a forwards motion. That muscle is working really hard, it falls into play. So a lot of times people with this type of trigger point will actually describe pain in the back of the head, top of the head, or even more so sometimes around the eye. So people a lot of times will call this a migraine, but in essence, sometimes you can just palpate that muscle, or I can press on that muscle and it will send a referred pain or a pain pattern, kind of reproduce that pain. And that's usually how we find these things in the clinic, is that if you press on the muscle that if the clinician presses on the muscle that may be giving somebody pain, it can actually cause more, if it reproduces that sensation that they have, many times that can lead you to say, okay, there's a muscle that's really tight over here. Okay, another one is suboccipitals, which is basically those small, tiny muscles at the base of the skull. As you can see in the picture here, this is actually on the left side here. This is a picture looking from the back. So, some of these muscles here are really just the top two cervical vertebrae, so the top two vertebrae in the upper part of the neck here. So again, with whiplash, those are two areas of those muscles are working really hard to kind of stabilize the neck. As well as, imagine if you're forward head all the time watching the computer, all those muscles in the back are constantly trying to hold it in place. And sometimes people find pain that they have on the sides of their temples. And as you can see here on the bottom here, those suboccipital muscles are common players for that. Another common one is the temporalis muscle. And this actually has to do more with jaw pain. So sometimes someone might have a jaw issue. Some people might think that their teeth are hurting them. Sometimes that happens. And that temporalis muscle is actually a big muscle for involved in opening and closing the jaw. Those are the muscles those are actually literally probably the muscles that people touch when they're trying to loosen up their muscles after getting some tension in there. Yeah, so these are, I would say, I chose these ones, the trapezius, sternocleidomastoid, the suboccipitals, and the temporalis, because I think these are 4 common ones that have to do with headaches, especially chronic headaches where people have those trigger points in those muscles and those muscles aren't releasing. Okay, so physical therapy, pretty straightforward. I kind of wanted to keep it simple here. It's pretty much, let's release the taut muscle, and then let's train the muscle with more endurance and more strength. Again, a muscle that has trigger points in it is usually more often than not a weaker muscle. Because the muscle is weaker, it's developing these trigger points, it's working really hard. There's obviously some sort of muscular weakness or muscular endurance issue. If we don't upgrade the computer after we restart it, we're not going to get better, it's just going to come back again. So we can release the taut muscles, that's restarting that computer, but then we got the training muscle endurance and muscle strength, which is giving it an upgrade. So I want to specifically talk about this a little bit because this is actually more so the treatment that I've been doing in the clinic. Guys, giving a plug for outpatient physical therapy at Weiss. But this is actually a picture of somebody's trapezius muscle in the upper neck here. So what we do is sometimes we use a needle to actually specifically find those trigger points or find those little bands of muscle and put the needle into the muscle to get the muscle to release. So it's kind of like a reflex where you stick the needle in, the muscle will start to shorten, so it reflexively shortens and then releases. And this is a very, I like it a lot for head and neck stuff because this sounds a little scary, but the needle is the deepest you'll ever get in terms of trying to release a trigger point. I mean, some of the needles can go pretty deep, and we'll talk about that in a little minute, but those needles can actually release muscles that normally it's really hard to get with your fingers if you're trying to manually release a muscle. So dry needling started, it really became more popular with her name was Dr. Janet Travell. She was actually a cardiologist who actually was John F. Kennedy's cardiologist. She taught, I guess she, as we talked about the heart, right? The heart has a referral pattern that comes from, sometimes, the heart can have pain in the heart and then it goes down the arm. So the referral pattern is the same for the heart muscle, whether it is for a muscle of the body. So she was the one who kind of started to look more deeper into referral pain patterns when it comes to muscle pain and referred pain. And then over time, I took this course this is Jan Damerholt. He's a physical therapist. He was the one who started this company that deals with trying to came up with dry needling. So it's pretty much, the question was, we do something called a trigger point. They have trigger point injections where they put a needle into the trigger point to get the muscle to release, and they inject lidocaine or some sort of anesthetic. The question became, is it the needle is it the medication that's giving them the pain relief, or is it the needle when it goes in the needle and the needle gets that little twitch out of the muscle and the muscle releases? Is that really what's giving people pain relief? And that's kind of where dry needling became more popular. So dry needling is pretty much using a thin filament needle. So it's a solid needle. There's no gauge to it. So it's not injecting we're not injecting any medication or any substance. It's completely solid. The needle is placed in the trigger point and just kind of tapped in there to get the muscle to release. And this is a picture here of the kind of the mechanism that we talked about before, those little taut bands that are in the muscle, and then we kind of use the needle to release them. Dry obviously refers to absence of injecting a substance. So this is a picture of an actual trigger point injection where the doctor might put the needle into the body might put the needle into the muscle belly to get the muscle to kind of inject some of the substance into the muscle belly to get it to release. So this is an example. So dry needling is called dry because we're not injecting anything. There's no gauge to it. So we're not injecting anything. We're just putting a solid thin needle into the muscle to get it to relax. So everyone's probably asking, how safe is this? It's actually relatively safe. I mean, if you think about, for example, aspirin. Aspirin has a 18.7% adverse reaction, meaning a negative reaction or a negative effect from a medication. Dry needling on the contrast, really the only big issue is it's 0.04% adverse reaction, and that's including bad bruising. And the main thing that people are worried about are getting, hitting the lung, which I've been trained very carefully not to do that. I've been doing it for 2 years. I have not punctured anyone's lung, so everyone can rest assured that won't happen. But that's pretty much it. It's a very, if you think about the statistics of it, it's 0.04% adverse reaction compared to, some of these over-the-counter medications, which we see is, aspirin, ibuprofen, and so forth. All right, that's actually, that's pretty much what I have right now. Let me open up to questions, because I bet people probably have some questions. Let me, okay, Judy, how are we on time with questions?
Let me check the time. I think we're pretty good. It's 1
Okay.
o'clock. We're doing good. I have a question here.
Yeah,
You can come up. Yeah, I'm just gonna have them come up and speak to you. Can you hear me pretty good?
yeah, I can hear you. Yeah,
Okay, great. That way I don't have to, they don't have to scream
yeah.
across the room. Thank you, Nathan.
My question is, my question over there. Should I talk to this?
Just talk to him.
Yeah, my question is, it's been 2 months now. My blood pressure is so high. It was 174 over 110 post 100. So my father told me to take the propranolol 40 milligrams with the furosemide 40 milligrams, one in the day and one after 12 hours. And that has managed my blood pressure. I saw primary care yesterday and he put me on different medicine and he hasn't given it to me yet. So when my migraines happen, they don't go away. And I can do whatever I want to do. They don't go away at all for hours and hours. But then my neurologist gave me sumatriptan and she told me to take one. And if it doesn't work, then take 2. After 2 hours, take 1 more, but not more than 4 in a day. So my question is, how can I stop the migraine from happening? And if it does happen, is there some medicine or some herbal thing that I can take to stop it? Because it doesn't stop.
Right. My initial question, my initial comment to that would be, because you have that history of blood pressure, I think you have to make sure that everything is ruled out in terms of your migraine and how it's associated with your blood pressure fluctuation. I think getting that situated would be the first step before doing anything. If once your primary care physician or the other specialist makes sure that that blood pressure, that blood pressure is under control, then you can take that variable out and you'll know that now maybe my migraine that I still have is related to something else, maybe muscle, maybe something else. But I think the first step before anything is just to get that blood pressure under control just so that you can make sure that the migraine is not coming from that. I don't know if that's what you were asking, but that would be is that kind of what you were going with your question?
Yeah, because sometimes it's the blood pressure that's causing the migraine. I know that's why I'm having a headache. But sometimes the headache happens without a reason and the blood pressure is normal.
You can always come in for a physical therapy evaluation and we can see if there's some muscle component to that. But again, yeah.
So what should I tell my primary care, that I need a physical therapy referral for migraine?
Yeah, you can always ask for a physical therapy referral. Migraine, headaches, whatever the case may be. If worst comes to worst, we have 1 session, we determine, hey, this is not in the physical therapy wheelhouse, fine. But if it is, then we can work on treating what we find. So I don't think it hurts to do it. Again, I would probably ask you more specific questions. We actually have a therapist in our clinic who specializes in vestibular issues, which is basically balance and kind of, more neurologic type stuff. And she actually has talked to me before. I've talked to her about it. vestibular headaches. So that might be something to talk to her about as well. So there's definitely resources in our clinic to talk about it.
What's her
Yeah.
name?
My name is Nathan.
No, what's her name?
Oh,
I
her
know
name is Morgan.
Morgan, thank you.
Yeah.
And can I get this paper you're doing, like on my email or something?
You mean the treatment, you mean?
No, your webinar, is there a way I can have it
Oh.
on email?
I'm not sure. Does Judy?
Yeah, we can share it. I have her email address. As long as I have everybody's email address, I can share that with you specifically, this PowerPoint presentation.
Thank you.
Mhm.
Are there any more questions?
Yes, I have a question. This is Sharon Richardson.
Mhm.
I'm having problems with headaches, and I've been in physical therapy for a while. So I had whiplash. So does dry needling stop the pain?
I would say that the assessment that, obviously there's some sort of, the neck and the head were involved in trauma.
Mm-hmm.
So we would first look at your neck and see what's going on with your neck. And see if there's some hypomobility or too much mobility or too little mobility in your neck in terms of the joints. But we'd also look at the muscles. So it is possible for dry needling to help with chronic pain, especially pain that comes from a traumatic event like a car accident.
Mm-hmm.
But again, I think it's also going to come down to strengthening and endurance exercises. Whenever a muscle is traumatized, it's affected not just, the dry needling can help the pain and can stop it, like we talked about. But I would say that it's more of a physical therapy plan of care that we do. So it's dry needling and muscle relaxation is just a small piece.
Mm-hmm.
Big picture wise, it's going to be to try to get those muscles back on track or upgrade those muscles again. So
Well,
yeah.
you know what? This is like my third time being in physical therapy. And so this time I've been in physical therapy for like over 2 months, this recent one, right?
Mhm.
So it's like I need something because I still have headaches. The physical therapy has lowered it, but I'm still having headaches. So I just need something to stop the pain.
Yeah, I mean, it's definitely worth a shot. No pun intended. But yeah, I would say that we could always take a look at you and assess you. Morgan does dry needling as well, so there's multiple people doing dry needling now. So I think, again, I like it because it gets a little bit deeper into the muscle than you normally would.
Mm-hmm.
So, and sometimes there are some muscles in your head that are just really difficult to actually get to. So,
But I'm still confused. What exactly is the dry needling doing? Is it pinpointing exactly where the pain is coming from? Does it reduce the pain? What is it doing? Because I'm in physical therapy.
yeah, so dry needling is literally you're taking the needle.
Mm-hmm.
I'm fine. Let's say, for example, I'm looking for the muscle band,
Mm-hmm.
and I'm putting the needle into the muscle band or a little spot there that is reproducing your pain, and it releases the muscle. So it's like a reflex.
Oh.
So it's kind of like these are the muscle fibers, and they're all tight.
Mm-hmm.
So you stick the needle in, really, kind of like you stick the needle in, it reflexively will tighten again, but by doing that, it like unhooks it.
Oh,
So-
it relaxes the muscle.
It's like a very deep, intense massage, if you want to.
Oh, okay, I get it now. Okay, all right, thank you.
Mhm.
Compared to what she was talking about, the needling,
Mhm.
I want to know what is the difference between the dry needling and acupuncture?
Oh, that's a great. Yeah.
Acupuncture is very beneficial for all parts of your body, not just your headaches. It's very beneficial for everything. So I'm wondering now if acupuncture is the same as needling or if there's any difference in it.
Yeah, no, that's a very good question. I would say they're similar in ways and different. I would say it's similar where it uses a very similar needle. And it's similar in the fact that acupuncture will also deal with trigger points in the muscle. I would say that dry needling is a lot more deliberate and specific in terms of putting the needle directly into a taut muscle band. Acupuncture, for just to simplify it as much as possible, acupuncture is more of a systemic approach. So for example, if somebody has irritable bowel syndrome, or they have an upset stomach, they may find these meridians or energy patterns on the body and put multiple needles in certain areas to kind of address that systemic issue. Dry needling is a lot more specific. And I would say treatment wise, if you looked at the procedure, dry needling is a lot quicker. It's just 1 minute, it's just, a couple seconds, boom, 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 trying to get some twitches out of the muscles. Whereas acupuncture may actually, you may have the needles inside of you for a lot longer. So it's similar and different.
Oh, so dry needling is just like you just sticking into the muscle.
Right.
And you're not letting it stay in there, you're just sticking it in there and taking it out.
Yeah, I would say that look at dry needling as a quick acupuncture of the muscle.
Mhm.
But it's a lot more specific, and the person who's doing it is looking for a twitch response out of the muscle. So you're actually physically in some of the muscles, you can actually see the muscle twitch.
Oh,
So there's like constant feedback on what's going on. And the skill of it is trying to find those spots in the muscles that are tight and kind of balled up, like we talked about. So for example, yeah, like right over here, it's like finding those little nodules inside that muscle, trying to look for them and then putting the needle in them. So
oh.
there's a lot more longer of a conversation to show the difference, but is that enough to describe the difference? That makes sense?
Somewhat, yeah.
Somewhat?
I have another question. So do you need a doctor's referral to get dry needling, especially if you've had physical therapy already?
You need a doctor's referral for the physical therapy. The dry needling is included just like any other treatment that we do. So
Oh, okay, I got you. I got you. Okay,
Yeah.
all right, thank you. All
yeah.
right.
Are there any more questions on this end? No more questions? Yes. Mhm.
I have one more question.
Uh-huh.
Before I see a physical therapist and everything and my blood pressure is resolved, is there a certain way I can lay down or sit or any exercise you recommend that I can do to make the headache bearable when it's happening? Anything at all?
Yeah. I would say that because I haven't met you and I don't know your whole health history.
You know me, I'm saying that I come again and again at your place.
Right. I think it would be better if we did it in person. Because I
Okay.
wouldn't want to give you any information without me discussing it with you in more detail. So
Are you in the hospital right now?
not right now, no.
Oh, okay.
Yeah.
Will you be here tomorrow or on Friday?
I will be here tomorrow. Yeah.
Okay.
Okay.
Okay, thank you.
Anyone else for questions? Thank you. Nathan, they said thank you very
Thank
much.
you.
Well, you're welcome. All right. Thank you for having me. I hope-
Thank you so much. I enjoyed this. Thank you.
All right. You're welcome. Thank you.
And thanks again.
Mhm. All right. Signing off.
We can sign off.
All right. All right. Nice meeting everyone.
Online, is there like a certain, how do you?